Namaste friends, Dr. Harsha here from Vice Academy. Another snippet, very important concept of ETC and DCS. So DCS we know, damage control surgery, and ETC is another concept called early total care. So which patient you need to give ETC and which patient you need to give DCS, MCQs can be framed on this. What we need to understand is there are two modalities of trauma that occur in a victim who has suffered an accident or some injuries in a mass casualty. Thing is, first one which happens at the site of accident is called first hit. So when the patient comes to us to the ER, we evaluate and we see what happened in the first hit. So head to toe examination, rollover, everything we examine, and we grade him according to ISS, injury scoring scale. And after this, what happens is we should bear in mind, we should take into the physiological status of the patient, like his core temperature, how he is like hemodynamically stable or not, his urine output, lactate levels, base deficit, all these things, and if there is any requirement of transfusion. So when you take all these things into consideration, we will get an idea about his physiological status. So when we are trying to implement ETC on this patient, that is early total care, what happens is we are again subjecting the patient to certain amount of trauma. So we should be in a clarity if the second hit, that is our iatrogenic thing, our surgery, will it further deplete his physiological status. So after lots of research, they found that early total care has given rise to more mortality and morbidity when compared to damage control surgery. So given an option, if the patient is not that hemodynamically stable and physiologically active, then it is better to go for a damage control surgery rather than ETC. Let us assume one case scenario, a patient is taken up for multiple trauma, is on the operating table, and your goal is to do a ETC protocol. You wanted to head injury is there for extradural hematoma, and you wanted to do a bladder repair or something like repair of a liver laceration. So what happens is, once the surgery has been progressing, suddenly the patient becomes hemodynamically unstable. Then you have to immediately shift the protocol from ETC to damage control surgery and stop the procedure and try to do some damage control and come out. For example, there is a grade 3 or grade 4 liver laceration. Actually, you wanted to go in and explore. Anyways, they have taken an anesthesia. You wanted to go in and explore. But now the scenario has changed because suddenly on table his hemodynamical status has deteriorated. What you can do is you can just, if it is imperative, you just open the abdomen and pack the abdomen and come out. So you have converted the ETC into a damage control surgery. So there are certain parameters, very important table that they have given in Love and Bailey. So certain points that we need to remember from that is, one is lactate levels. You need to see the lactate levels. If the lactate level is greater than 5 millimoles per liter, then definitely he will be converted into a DCS protocol. And also if there is massive requirement of transfusion, or if the core temperature is dropping below 34 degrees centigrade, or if his pH is dropping below 7.2, all these things mean that he is not hemodynamically stable. So in these situations, you need to plan for a damage control surgery rather than a early total care. Thank you.